Hello, everyone, and thank you for joining us for this week's Department of Medicine Grand Rounds. We are very lucky to have two very special presenters from the Cambia Palliative Care Center of Excellence in a special joint presentation. Our first speaker, Dr. Curtis, came to the University of Washington as an intern in internal medicine in 1988, where he stayed to complete his residency, chief residency at the Seattle VA, and pulmonary and critical care fellowship before joining the faculty. And in addition to his busy clinical practice in critical care, he has an active research program focusing on palliative care research with continuous NIH funding for over 25 years. He currently holds the A. Bruce Montgomery American Lung Association Endowed Chair in Pulmonary and Critical Care Medicine and is the founding director of the Cambia Palliative Care Center of Excellence at UW-Medicine. And our second speaker, Dr. Susan Merel, is a graduate of the University of Chicago Pritzker School of Medicine and completed internal medicine residency and a clinical geriatrics fellowship here at the University of Washington. She currently practices hospital medicine at the University of Washington Medical Center and palliative care at Harborview Medical Center. I've had the privilege of working with her in her other roles as well as the Associate Director of Medicine Student Programs for the Explore and Focus phase and the Education Director of the Cambia Palliative Care Center of Excellence. I just want to say thank you to you both for being with us today and for sharing both your knowledge and passion with us in today's Grand Rounds presentation. As always, we welcome questions and comments at any time via the chat function on Zoom, and we'll have a consolidated Q&A session at the end of the talk with both of our speakers. Dr. Curtis, feel free to share your screen and get started.
Great. Thanks so much, Johnny, for that introduction. I am excited to be here presenting with Susan as Grand Rounds. I still remember my first Grand Rounds about 20 years ago in the T-Wing, and this is a little different. I'm sorry I can't see people in person, but I'm excited to be here. Let's see if I can, there. Okay, so we're going to talk about promoting goals of care discussions at UW-Medicine, merging research, education, to improve clinical care. Neither of us have any financial conflicts of interest to disclose. I do like to disclose our funding sources, which include the healthcare system, UW-Medicine, the Cambia Health Foundation, as well as a number of the institutes at the NIH and PCORI. I also want to make another disclosure of sorts. And I want to be clear, this is not an apology. My primary mentor when I was a fellow, Len Hudson, used to say, never start a talk with an apology. And I really like that advice. So this isn't an apology, but an explanation. I have been recently diagnosed with bulbar onset ALS. And it affects my speech. It sounds like I've had a couple of drinks. I want to assure you that I haven't. And I also want to say that I'm doing very well besides these mild bulbar symptoms at this time, and really looking forward to continuing my work, developing and growing the center, our research programs, as well as the mentoring. I want to actually turn it over to Susan for a second, who wanted to say a few words about that.
Yeah, so we're palliative care doctors, and we acknowledge emotions. And Randy's disclosed this news in a really wonderful way to a number of us, but there may be people who are hearing about his diagnosis for the first time on Grand Rounds. So I just wanted to pause and say many of us are feeling sad about this news. I'm also feeling really grateful for all of the mentorship that Randy has given me and many of us and is continuing to do. So again, just having taken a moment to acknowledge that emotion, Randy's going to move forward with his talk.
Thank you, Susan. So a brief overview of the Cambia Palliative Care Center of Excellence. This was launched by UW-Medicine in 2012. It became the Cambia Palliative Care Center of Excellence in 2014 with a very generous naming grant from the Cambia Health Foundation. The mission is to improve palliative care received by patients with serious illness and their families, and to support the clinicians who provide this care. And we do this through developing innovative clinical programs, educational resources, and the evidence base to improve palliative care here regionally as well as nationally. From the beginning, the center has very much been focused on both primary palliative care, that is care provided by all clinicians caring for patients with serious illness, as well as specialty palliative care, care provided by the palliative care specialists. And one of our main priorities is to both promote both these and find ways to integrate them in the most effective and efficient way possible. The integrated palliative care programs across UW Medicine include the clinical programs run by Jim Fausto, who is the medical director for palliative care, as well as Blair Mills, the palliative care administrator. And then the center works closely with Jim and Blair. And in fact, Jim and Blair are both part of the center. And we have an amazing leadership group that includes Susan, as well as a number of others listed here who have helped promote and propagate the work of the center. From the beginning, we have also been interested in incorporating all the components of academic healthcare, clinical education, and research. And in fact, we really have tried to do this through integration, not silos. And really thinking of this sweet spot where these three intersect as an opportunity to build and promote a learning healthcare system. I want to use one example of the way that we're doing that, which is something we call the Jumpstart Guide program. And this is to develop and evaluate a communication priming intervention to improve goals of care discussions. And if you think about how you might do that, we've approached it with a couple of different approaches. We've taken a bi-directional approach, prompting and guiding both patients and families as well as their clinicians. And we've taken a clinician-only approach. I'm going to show you some of the work that we're doing. We've also done this in both the outpatient setting as well as the inpatient setting. Many of you may have seen this. This is the Jumpstart Guide that may pop up in your email if you're taking care of a patient who has chronic serious illness in either the inpatient or outpatient setting, who's enrolled in one of these programs. It contains information about the patient, as well as some suggestions about how you might begin a goals of care conversation, and a reminder to document the goals of care conversation that you have in a short note. I also want to highlight these buttons on the bottom that allows you to provide us with feedback about whether this was helpful in this particular situation. I do want to take a step back and talk a little about how I'm using this term goals of care discussion, because different people use these terms somewhat differently. I think of advanced care planning as discussions about values, goals, and preferences for future care that could be with healthy individuals, individuals with chronic illness, or those who are imminently dying. And I think of goals of care discussions as the subset of those that are discussions of how your current goals should inform your current and sort of near future care. And this could be done with patients with chronic illness, what I would consider early goals of care discussions, or individuals who are imminently dying, or late goals of care discussions. And we're really focused with Jumpstart on prompting and promoting these early goals of care discussions. So why focus on goals of care discussions? They have been associated with increased quality of care and quality of life for patients, reduced psychological distress for patients and their families, and reduced intensity of care at the end of life. But frequently these don't occur for patients with chronic serious illness, or occur too late when patients don't have capacity or are stressed by what's happening to them. We looked at how we're doing within the UW Medicine system. Bob Lee, one of our junior faculty, published this paper in JAMA last year, a retrospective cohort study of over 1,800 decedents who died between 2010 and 2017 and who were admitted to the hospital in the last 6 months of life. Of these patients, 22% had a pulse form that requested comfort measures only, 42% requested limited interventions, the remainder of full treatment. We found that these treatment limiting pulse, comfort measures only, or limited interventions were associated with lower intensity care at the end of life. Having these discussions, filling out these forms, is associated with reduction in intensity of care at the end of life. However, we also found that over a third of these patients with treatment limiting pulse received care at the end of life that seemed to be pulse discordant. And so this highlights that there's really an opportunity to do this better. We found that risk factors for pulse discordant care included the absence of cancer or dementia. We do a little better there, not so much in chronic organ failure diseases. And also another risk factor for pulse discordant care was the presence of trauma. So let me talk a little bit about Jumpstart and how we're trying to promote these discussions and improve them. Our first trial of this was led by David O in the VA system, published in 2012, almost a decade ago now. This was a cluster randomized trial of 96 clinicians at the VA and 376 of their patients with COPD. This was our first Jumpstart that identified patient-specific barriers and facilitators to talking about end-of-life care, and then fed those back to patients and clinicians with suggestions about how to use the facilitators, address the barriers, and provided clinicians with patient-specific tips. We got a lot of feedback that these early Jumpstarts were way too long, way too many words, and so we've reduced the number of words, but it did seem to have a beneficial effect. The intervention increased communication with end-of-life care at a target clinic visit, was 11% in the control group, went up almost threefold to 30% with the intervention, although still only a minority of patients having these discussions. We also asked patients to rate the quality of communication at that visit, and we found that it increased. Baseline on a 0 to 10 scale was 2.1, which was low, and increased 0.6 points on this scale, which is a small and moderate effect size. And I'll ask you to remember these numbers, the proportion of control group and intervention, and the effect size for the next trial, because we are improving this intervention over time. This was a trial that was published in JAMA Internal Medicine in 2018, asking whether this bidirectional patient-specific communication primary intervention could improve goals of care discussions in the outpatient setting. Bidirectional in that, again, it went to the patient and the clinician, and patient-specific in that it used surveys from patients to help prime and guide these discussions. So again, cluster randomized trial, randomizing clinicians who provided primary or specialty care. This was done at UW Medicine and also at Swedish. Patients were eligible to be in the trial if they had a chronic life-limiting illness with a median survival predicted to be about 2 years. And then the intervention, the Jumpstart guide, was delivered to the clinician and the patient right before a target routine clinic visit. The control group was usual care, but they also completed surveys. And as you'll see, I think these surveys did prompt some communication, but the intervention prompted more. We had 132 clinicians, 24% racial and ethnic minorities, the average age of 47, a little more than half were female. Most were physicians, although we did have some nurse practitioners, and there was a range of generalists and specialists. We enrolled 537 patients, 21% racial and ethnic minority, Average age was 73, almost half female, and there was a real diverse group of qualifying conditions. So this is the primary result. The primary result was patient-reported goals of care discussion at that clinic visit. 31% in the control group now, which I think may have been prompted by surveys, but it went up to 74% with the intervention. We also saw increased documentation of goals of care discussions in the EHR with the intervention. We also, again, assessed quality communication using this quality communication scale. 2.1, again, in the control group. Now it went up to 4.6, which was a larger Cohen effect size. And this shows you the 4 items. How well did your doctor do at talking to you about your feelings about getting sicker, the kinds of treatments you want at the end of life, what's important to you in life. Those 3 all improved individually. Details of getting sicker went up, but wasn't statistically significant. In addition, we assessed patient-reported goal-concordant care. There was a trend towards increasing patient-reported goal-concordant care in the full sample. We a priori wanted to look at the patients with stable preferences from enrollment to clinic visit, since clinicians are more likely to be able to provide goal-concordant care if the goals are stable. And we did see a significant increase in those with stable preferences. From here, we've moved on to trying a Jumpstart in the inpatient setting. We recently finished a pilot trial that was funded by the National Palliative Care Research Center. This was a trial randomizing 150 hospitalized patients who were over 55, had chronic life-limiting illness, and for whom palliative care consult service was not involved or not yet involved. And we did this at Harborview and Montlake. The intervention was, again, a Jumpstart based on patient surveys delivered by email and in person to clinicians. This was pre-COVID, and in person to patients. And Bob Lee, one of our junior faculty members, is writing this up. The control group was usual care, again, plus surveys. And we did see an increase in goals of care discussions as documented in the EHR from 8%, quite low, up to 21%. We didn't see an increase in patient or family reported discussions. And I actually think that in the inpatient setting, this is a really difficult thing for patients and families to understand and grasp what we mean by these discussions, given everything that's going on. So I think what we've learned about Jumpstart so far is that it does increase occurrence and quality of goals of care discussions in the outpatient setting, both by patient report and EHR documentation. But this has been challenging to implement in practice because of the requirement of the surveys. And we're very interested now in looking at whether we can do this without surveying patients and families, but rather from data that's in the EHR. We also increased documentation of goals of care discussions for inpatients in a pilot study, although the prevalence of these discussions was quite low. So we used this pilot data to obtain funding from the NIA, the National Institute of Aging, for an R01 that includes 2 complementary randomized trials of the inpatient Jumpstart. The first is a large pragmatic trial where we're only doing the clinician facing, we're not surveying patients and families. In fact, we're not even contacting them, arguing that we're promoting standard of care, so we don't need to consent patients and families. We are randomizing the usual care or the clinician receiving a clinician-facing Jumpstart to ask them to consider a goals of care discussion. Outcomes are all assessed through the EHR. The second trial is a comparative effectiveness trial, asking the question of whether these patient and family surveys are actually producing a better result. And so this will be consenting patients or families and then randomizing them to either the clinician-facing Jumpstart or the bidirectional Jumpstart. And here we'll use the same EHR outcomes, but also survey patients or families at 1 and 3 months to assess additional outcomes like quality communication, goal-concordant care, and symptoms of stress. The inpatient, the first large pragmatic trial is the only trial I've ever done in my career that exceeded our enrollment targets. We actually have finished enrollment. We targeted 2,000 patients and hit 2,500. We kept enrolling because part of this study is to look to see at the subgroup of patients with dementias, and we wanted to hit a target of 400 there. We got close at 329, and I don't have the results to show you yet, but they should be coming soon. So I feel like the conclusions of my part of this talk then are that goals of care discussions have the potential to improve patient outcomes and family outcomes, and that we can increase them with targeted interventions. I really do believe this is an opportunity to integrate research, education, and the care we provide for patients and their families through promoting a learning health system. I think we're making progress, but there's still plenty of work to do. And then Susan and I wanted to give this talk together where I could talk about how we're using the research. And I want to turn now to Susan to ask her to talk about how we're using educational programming to combine with research to improve care for patients and families. So I'm going to stop sharing, Susan, and you're up.
All right. Thanks so much. All right, looks like it's shared. So I think this is the third time seeing this slide because we think it's really important. We think that one of the great benefits of the Cambia Palliative Care Center of Excellence is that we are all working together on clinical, including QI, education, and research. What's this model? What are the benefits of this model for education, specifically primary palliative care education or education of folks who are not going to do a palliative care fellowship, and maybe for myself as a clinician educator. So as I said before, mentorship and collaboration. The ability to share resources and modify them for educational level, I think I'm just starting to realize this, and I have a little ways to go, but actually just the other day, I spoke with a nurse practitioner from cardiothoracic surgery that wanted to teach her colleagues how to better deliver serious news and respond to emotion. And I said, you know, I have some materials on that because we teach the hematology oncology interns, and it won't be exactly the same, but we can modify that really easily. During the pandemic, I was so grateful to be able to pivot my educational programs without like having to search for new resources to any great extent. I was in this role with the Cambia Center. I was focusing a lot on medical student education, and I'm still doing that. But at the time, the medical students were sent home, right? And some of the programs that we had for them involved them talking to patients, like in the surgery clerkship, for example. The need at that time was talks for clinicians, cardiologists, hospital medicine, helping them deliver serious news about COVID or complete other communication tasks related to that. So I was able to pivot to that. Just a taste of some of the education programs in primary palliative care that are in any way affiliated with the Cambia Palliative Care Center of Excellence. I'm not in charge of all of these. We have a lot of educators that are affiliated with them. We're partnered closely by an organization many of you may be familiar with, started by Tony Bach here and others, called Vital Talk, that teaches serious illness communication. So we use a lot of those frameworks. Some of the education programs that we have include a wonderful yearly Pacific Northwest Palliative Care Conference, truly multidisciplinary, really strong showing from nurses on Zoom, of course, this year, but we're looking forward to going to a convention center and having that again in the future. We have a graduate certificate in palliative care. It's a separate entity now, but those folks are also have close ties to the center. If you are a practicing clinician looking at wanting to have a year, evening, and weekend program that will teach you a lot of palliative care skills and how to implement them in your institution, please hop onto that website. They're actually still enrolling for this next year. I've done a lot of work along with Melissa Bender of Family Medicine on education in the medical school, including some really robust clinical electives and exercises embedded in clerkship. So now every student going through their clerkship in medicine delivers serious news or watches somebody else deliver serious news and debriefs. They do some advanced care planning. There's a new pilot program in surgery where they're gonna discuss goals and values with the patient making a surgical decision. So a lot of really, I think, great stuff happening there. There's a lot of communication trainings for residents and fellows. Again, I don't run all of these, but the center helps, for example, with finding actors to play patients for simulation. And then more recently, I've been doing a lot of education for UW medicine clinicians, initially COVID specific, and now partnering with Randy's PCCE or Jumpstart study focusing on goals of care. There's a national background for this work. Luckily, I did not have to reinvent all the learning goals and objectives for everybody. There's been some really, even though palliative care is a little bit of a newer specialty, there's been some wonderful consensus work done on what should every graduating medical student and every graduating resident in any specialty really be able to do. And just shouting out to Aquifer, which is a really wonderful national company that develops high quality online education. Kristen Schaefer, the first author of that paper, and I'm on the Aquifer leadership team for this project. We are putting together some national resources for health profession students, not only medical students, but nursing students, social work students, so that in the future, if you are a medical educator, maybe at a smaller institution, and you don't have enough palliative care trained people to deliver this education themselves, you can have some guidance on integrating this into your family medicine or psychiatry or surgery clerkship. Just as an example, these are just 3 of the competencies for residents, and the medical student ones are appropriately just slightly different, but these are 3 of the 12 or so competencies that we would really want residents to have when they graduate. So folks should be able to explore patient and family understanding of illness, concerns, goals, and values, and identify treatments that align with these priorities. They should be able to demonstrate effective patient-centered communication when giving serious news. They should be able to reflect on their own emotional reactions, model self-reflection in their team, and acknowledge team distress when providing care to seriously ill patients. So just an example of one way that we've been operationalizing these competencies, and it's just a project that I'm so proud of for so many reasons. I did not start it. Caroline Hurd, who now practices mostly in Oregon, and her photo is down there at the bottom. This was her project that I gratefully have continued with. And Amanda Shepard, the other picture there, Amanda is an assistant program director in our internal medicine residency program. So the residency program has moved very appropriately, a lot of didactic or workshop trainings that used to be like in the first week of internship when you're probably not going to remember, or at some random time during the year. She has moved them right close to the point of care so that the first morning of your MICU rotation, your wards rotation, your HEMONC rotation, you get some really specific training in the things that you're actually going to do during that rotation. And so I like to say that Amanda teaches the procedures that involve needles and ultrasound, and I and my colleagues teach the procedures that involve talking, right? So thinking about communication skills very much as a procedure. And so we have a teaching session on leading a family conference with a trained actor. It's a robust teaching session. It's a couple hours long before the MICU rotation. We have a shorter session on practicing delivering serious news for residents starting their oncology rotation, and 2 new sessions that are going to start this year, both of which have been initiated by internal medicine residents themselves, and I'm really excited about moving forward with those. In terms of how my work has integrated with Randy's, he asked me to do some clinician education affiliated with his PCCE or Jumpstart study. So I developed frameworks that clinicians could use for 10 and 30-minute goals of care discussions that are meant to supplement the Jumpstart form. So the form that you saw is, quite short. And so if you are not really comfortable having a goals of care conversation, it's reasonable that you would need just a little bit more to get you started. Right now, we're focusing on study populations, mostly on general internal medicine and residents at Harborview and UW-Montlake. I'm deliberately repeating versions, so I'm going to give a version of this talk in a minute. And some of you have heard a version of this talk before. That's on purpose, right? Because repetition is one of the ways we've learned. And then I have an infographic for resident team rooms to reinforce these talks. Here's kind of my overall framework that if you have just a few minutes, if you have 5 or 10 minutes, you can plant a seed. You can just get a little sense of a patient's goals and values that you can carry forward and use in the future and pass on. If you have 25, 30 minutes, you can dig a little deeper. You can maybe help the patient or family member make a decision. So I'm going to move into I'm not going to time it, but a sort of 8 to 10 minute version of the talk that I've been giving. Goals of care conversations, why, when, and how. So why? Randy already gave you the kind of research reason why. There's really good evidence that these discussions lead to better outcomes. Conceptually, one of the reasons that I do frequent goals of care conversations with chronically ill patients is it helps us identify big groups, right? We know from research that 5 to 15% of older adults are what we call vitalists. Any life is worth living. 15 to 25% want very little life-sustaining treatment near the end. Oh, I would definitely want hospice, Dr. Merel. I don't want any procedures. A majority are in the middle or undecided. And so when we explore folks' goals and values at multiple time points, we're able to sort of say, oh, gee, this is where this person is right now, and ideally tailor our recommendations. So it's not about saying you need to be on comfort care or you need to get chemotherapy, but what are their goals and values? And then you can use that to make recommendations. So I've talked about why, now I'll talk about when. So if you practice medicine at UW-Montlake or at Harborview and you get a Jumpstart, guide, then you should definitely have a goals of care conversation, but you should have it even if you don't, right? So here are some of the situations in which, in my job as a hospital medicine clinician, for example, I will have a brief conversation about goals of care. Anybody with a new or worsening diagnosis, a frail older adult who hasn't had this kind of conversation recently, somebody with a change in functional status, somebody with a prolonged hospitalization, or somebody who just, you walk in the room and you feel the suffering. And you wonder if some of that suffering is the fact that they're in the hospital or that we're doing a zillion procedures on them, and you wonder if that's really what they want. So how? If you have 10 minutes, you can plant a seed. Here's how I get started. We've used the term goals of care like 50 times in this talk already, but I don't use it very often with patients. If you are calling me up for a palliative care consult at Harborview, please use the term goals of care. I understand that, you understand that. It's just not a meaningful term for patients, and many patients have been in the situation of us setting goals for them and then they don't meet them, right? If your A1C gets to this marker, then we can do this, right? And that is not what this is about. So what I say instead is, could we talk for a few minutes about what is most important to you so that we can make sure you're getting the best care? The next thing I do is assess their understanding of illness without using the term understanding, because that can feel like a test. And it's not a test of the patient, right? It's a test of us. It's a test of the medical system and how well have we explained what's going on. So instead of saying, what's your understanding? I'll say, what have you heard from other doctors about your illness? What is your perspective on your medical situation? And then, so again, I've opened it up. I've assessed their understanding of the medical situation. I've clarified some of those things, but just resisting the temptation to launch into a big medical explanation at that moment. Then I'll choose a topic to explore. And what I will usually use, the questions that I will usually use is, what are you hoping for the future? What are you worried about? So asking the patient about their hopes and fears. And if you haven't tried this, I urge you to. It does feel a little awkward at first. That particular language was introduced to me when I was a medical student at the University of Chicago by Nicholas Christakis, and it probably was our one talk on palliative care. And I have practiced using those terms, which I suggest that you try if they sound like something you can say. Other questions are, what makes life worth living to you? If you were to get sicker, what would be most important to you? And then pause, right? And really listen. So really good evidence for letting the patient and family talk as much as possible, even if the overall time that you have is brief. And the study that I think most acknowledges this in my mind, Randy, I think, was on this study. It was a study of goals of care conversations for patients in the ICU at UCSF and one, I think, maybe Harborview. And they just recorded the conferences, and what they found was correlated with increased family satisfaction and decreased conflict with physicians was how much of the time the family talked, not how long the conversation was. These were about 30 minutes. And then, so when you open silence, sometimes people will have emotion, right? And so we really want to respond to emotion explicitly. If you were somebody that used to rely on your facial expressions and body language, we now know we can't do that because we're covered up by a mask, but it was always really helpful even when we didn't wear masks. So folks have an emotional response to a serious illness. conversation, and emotion can shut down your cognition. When you respond to somebody's emotion verbally, it helps the patient feel cared for. It helps them retain information. And so this is the mnemonic that I use and teach. And this is from the Vital Talk group. They have a great app that will remind you of this mnemonic: naming, understanding, respecting, supporting, exploring. So naming the emotion. I wonder if you feel upset about the news I just told you. Understand. Anybody would be angry about that situation. Respect. I use this one a lot now because truly people are working really, really hard to get medical care during COVID, separated from their families. You have been working so hard to help your husband, brother, son get appropriate medical care. Support. We'll be with you. Explore. Tell me more. So then after I've responded to the emotion, if this again is just a 5 or 10 minute conversation where I'm not making a decision, I will just align with their values. It sounds like you are hoping to have better control of your shortness of breath and spend more time with your family. Am I getting that right? And then always document. Really important, even when no decision is made. Maybe even more important, because if you do a pulse form or something like that, you can find that in the medical record. But what I'm talking about is 3 sentences at the end of my daily note, at the end of my discharge summary, at the end of your clinic note. I talked about goals of care with so-and-so. He is hoping for X, Y, and Z. Really, that's it. And then, of course, if there was a decision that was made, then documenting that as well. We are working, and the Cambia Center has been involved in this. We're working on ways to streamline this in Epic. For those of you practicing in the UW system, stay tuned. So again, my 10-minute framework for goals of care conversation: open up the conversation. Ask about their goals and values. Specifically, I ask what people are hoping for and what they're worried about. Pause and listen. Respond to emotion. Align with the patient's values. And then document. I've made an infographic. We have it up at some of our team rooms. If you are in the health sciences building today, you can come to my office. I have some of them in a little pocket outside my door. I can email you a copy if your group could use a little reminder like this. So in conclusion, for the talk as a whole, again, goals of care discussions have the potential to improve patient outcomes. They can increase with targeted interventions. Communication frameworks help us conduct them frequently and efficiently and in a patient-centered manner. This is an opportunity to integrate research, education, and clinical care. We're promoting a learning healthcare system. Junior faculty are benefiting from mentorship. We're making progress, but there's still work to be done. Thank you so much. And it looks like we have plenty of time for questions.
Absolutely. Thank you both so much. I know one of the oddities of this format is the silence to which you speak. There is resounding applause in the chat and a number of comments for both of you, just about how meaningful this work is, how wonderful the presentation, and how many lives you've touched. And so thank you so much for being here with us. A couple of questions just to call them out so that you can answer them for everyone. Number one, I think Dr. Curtis, you already answered this directly in the chat, but speaking to your experience at the VA and sort of whether more tailored Jumpstart interventions there for specific populations in general, like veterans, benefit from that type of approach.
Yeah, I think the VA has been a leader in developing palliative care programs and as well as education in this area, and I think ours is particularly strong. There isn't a Jumpstart program there, and I think part of that is because we haven't really developed one that could be easily implemented across a large healthcare system, and that's what we're trying to do now. The patient surveys are challenging to implement.
Another question, maybe to you, Dr. Merel, was about how are we working to educate here at UW allied health professionals, including psychiatric providers, case managers, long-term care providers, and in-home care providers?
Yeah. I am just getting my head around what is happening everywhere. The Pacific Northwest Palliative Care Conference is open to everybody, and a lot of folks in those job descriptions went to that. We're actually expanding that to a periodic shorter sessions over Zoom, so perhaps that'll help us reach more people. The palliative care, the PCTCE graduate program is open to most professions. So that's another thing. There is more and more happening in our other schools, the nursing schools. I'm not involved in all of it, nor should I be, right? But there is a lot happening that's not just for physicians.
Great. I did post a link in the chat for everyone in case you wanted to take a look at those training certificate programs and see some of the programs available. And again, feel free to keep the questions coming in the chat. Yeah, we can get a link for the palliative care conference as well here in a moment. Any advice on how to help learners deal with a situation where the learner believes the patient should want less intensive care, but the patient and family want more? So speaking of that, identifying those patients who are vitalists.
Yeah, should I probably take this one first? And I think I follow you on Twitter, Theodore Awashnia. So really, really good question. Part of that is identifying our moral distress about that situation, right? So the first thing I do when I get that kind of call as a palliative care consult attending is just debrief with that learner or clinician and acknowledge that it doesn't feel good, right? That it doesn't feel good to provide what we think is futile care or near futile care to somebody that we think is dying, right? But that's actually separate from aligning care with the patient's and family's goals and values. So just reinforcing that we need to explore those things, not offer care that is futile. And we allow DNR orders for medical futility. That's a little off the topic of this talk, but we do in our institutions, UW and Harborview do that. And then once we've explored and maybe we're not going to provide certain kinds of care, but maybe also we're not going to ask as much, right? Because that's one of the things sometimes we do with our moral distress. They can't be sure. So those are my thoughts. I don't know if Randy has anything to add.
No, I agree. And I think, as Susan said, the goal here is to understand patients and families' goals and values and try to meet those. We don't always agree with them. I will say that a big part of doing this well is supporting patients and families so they understand the prognosis, have the emotional support to make informed decisions. But some may still make decisions that we don't agree with. And our goal is to form care, produce care that matches their goals and values when we can.
Great. And I did include the link here for the department's latest news, so you can keep up to date with the announcements about conferences. A research question for you, Dr. Curtis. How in these trials do you measure goal-concordant care, which sounds like a tricky one?
It is indeed very tricky. And I think there have been a lot of attempts to do this. I would say some of them don't work. Some work better than others. And I know there's amazing work going on now around the country to try to develop better ways to measure this, including by some of the names that I see on the chat list or on the participant list. what we did is we took the approach of measuring patient-assessed goal-concordant care by asking patients what their overriding goal was. And we actually dichotomize it into care focused on extending life as much as possible, even if you're uncomfortable, or care focused on comfort, even if it means not living as long. That dichotomy was first developed for the support study in the 1980s, the items. That dichotomy is a false dichotomy. I fully admit that. Most people, almost all people, want both. They want to live long and be comfortable and have a good quality of life. But the goal behind the question is to ask people to prioritize. And people prioritize very differently. And so we ask them that question, and then we ask them, how is your care focused now? And that is one approach to assess patient-reported goal-concordant care.
Thank you for sharing that. I just sent another link out in the chat. Hopefully that would be helpful. I see some folks are raising their hand in the attendance. I wish we had the capacity to bring in numbers up to the panelist level to be able to share and speak. But unfortunately, we're limited to the chat. So please do let us know if you've got questions, and then we can reiterate them for you. Another question, I'm not sure whom would be better, but about the specific patient surveys guiding Jumpstart interventions. What are some of the questions that are presented actually to the patients there?
Yeah, so we asked patients, we've done a series of focus groups and one-on-one interviews to understand patients' experiences of the things that are barriers or facilitators to having this discussion. And so we created a list of common barriers and facilitators. We asked patients which of these apply to you and which is most important. And then we feed that back to the patient and clinician with a suggestion about how they might address that barrier or use that facilitator. Example, facilitator that's quite common is I worry about being a burden on my family. And so being aware of that allows you to then bring that up and say, it sounds like, or from what I can tell, what you said, this is a big issue for you. Maybe we can include your family in this and find ways to minimize that.
I think a good point here. I'm just going to read a little bit from the chat because, as we said, we acknowledge explicitly emotion, and I think this has been a very emotional and widely attended. One of the benefits of Zoom that so many folks could be with us here today from around the country, and indeed parts of other countries as well. So I'm going to go through and just point out some particularly poignant things, if that's okay with you two. I'll start with one that I found humorous. Randy, you look wicked handsome as always. Many of us from outside of Washington are also acknowledging that we feel sad and are amazed by Randy, and much love in particular from Ann Arbor. Incredible talk, incredible work. The bidirectional aspect of the studies are extraordinary. Thank you, Randy, for your passion, mentorship, and leadership in our field. Your work has most certainly shaped my career and the careers of numerous palliative and supportive care researchers throughout the country. Thank you for being you. Randy, my best friend before I moved here, told me the first thing that she knew about the Department of Medicine at UW is that they have a world-renowned palliative care center. You and your center rock always. Lovely to get to see you again, Randy, and to hear you speak about your longtime professional passions. And thank you so much for doing this talk and telling us all about your results. Outstanding talk. So good to see you here giving grand rounds on such a tremendous body of work. And many laments about the fact that only we panelists get to see these chats. And here we go, more things are pouring in, and I'm missing so many. Randy, you are my idol, and to so many other mentees. So glad that your smile is intact. So uplifting to see that, and a big thank you to both of you. And thank you both for the phenomenal talk and for training the mentors that are now training folks in our generation. And I will reiterate that. I'm going to try and capture some of this chat permanently. I think we can try and save all of that and give that at least to you two, if not to everyone. Randy, I have to remark upon my own. I take for granted how much you've imparted on me as well. Back in March, we were in the COVID ICU there in the very beginning, having goals of care discussions together, training new interns in that process amidst a new, frightening, and uncertain reality. And it was maybe the most impactful thing I will take away from my time in residency. So I certainly am grateful for training in a center of excellence that cares so much about the patient's experience.
John, thank you for that. And thank you for reading some of these comments, and thanks everyone who put all those in. I will say one of the special challenges of bulbar symptoms is if I become emotional, I become unable to speak at all. So maybe that's one benefit of not being able to see people. I better stop.
Yeah. Well, thank you everyone for being here with us today. In addition, the over 180 folks who attended here today is again an outstanding testament to the impact of your work and the impact of your presence in so many of our lives and in our training and through mentorship. Thank you both for your thoughtfulness, for educating so many, for mentoring so many, and for ultimately improving the lives and care of so many patients. And on that note, we can leave the chat open for some well wishes and I think maybe safely hide our faces here as the emotions set in and acknowledge everyone. Thank you so much, and have a great rest of your afternoon.
Thanks, Johnny. And Susan, thanks. You did a great job.
Thanks, Randy.
Agreed.